Hello, Professor DeCarli. Can you hear me? Thank you so much.
All right, I'm here. Sorry about that.
Nice to meet you. I'm Dr. Hu. I'm a neurologist and the director of a dementia center in Shanghai Hospital, Taipei Medical University.
Oh, well, welcome. Welcome. Glad to be here.
Okay, great. I'm looking forward to hearing your lecture. Thank you so much.
Oh, no worries. Do you plan that I just share my content and then walk through the slides? Is that how you'd like me to do it?
Yeah, maybe you can share your PowerPoint right now. Yeah, it's okay. Or later, Professor Fu Zhongling will share your talk. So maybe she will say something, and then you share or upload your PowerPoint later. Okay.
Because I can share. So this is my PowerPoint.
Okay. Good. It's good.
And I can see you. So I am.
Yeah. Very good.
There we go. See? And you can see me. I can see you.
And we can see your PowerPoint, your presentation.
Yes.
So your sound is good. So
Okay, perfect.
it's ready. Okay. We are waiting for the chairperson.
Yeah, and I apologize that I was. Let's see. I want to blur it. Can I blur my background? I'm in my office, home office. Oh, that's too bad. I don't think I can blur my background. Home office. There we go. Let's see what that looks like. Nah. Executive office. Ooh. Oh, there it is. Blur. That's it. Great. Okay. Great. Well, I hope that this is interesting. It will be completely different than John Morris's talk. I can assure you that. He and I have a very different perspective on dementia. He really likes Alzheimer's disease, and so I decided to give you all something a little different and look at vascular disease.
Yes, the vascular cognitive impairment or vascular dementia actually is the second leading cause of dementia in Taiwan. Yeah.
Yeah.
So VCI is very important for the dementia physician in Taiwan.
Oh, good. So these will be regular doctors and researchers as well, correct?
Yeah. Because the incidence of stroke is quite high in Taiwan. Yeah. But the challenge is
who am I going to?
Yes,
sorry, go ahead.
Yeah, I think the challenge is the mistype dementia. Yeah, especially in the old age.
Yeah. I think that's absolutely right. And we have this too in the United States. We're just coming around to recognizing it. So the audience will be neurologists and academicians, or will they be some practicing physicians as well?
I think both neurologists and psychiatrists, because in Taiwan, both neurologists and psychiatrists care the dementia patient. Yeah.
Wonderful. Perfect.
And I think some researchers also come here.
Okay, good. Good. How many people do you think will be on the attending?
Mm-hmm.
好，马上开始，好，要让那个这1个小时，好。 Hello.
Hi,
Hi.
how are you?
Fine. It's nice
Oh,
to
that's
meet you.
Oh, the pleasure's all mine.
Yeah. It is in the evening at Sacramento.
Yes,
Uh,
and I'm
so-
sorry to be talking through lunch.
yeah. And it is after dinner for you.
Yes,
Yeah. 超荣，我们是不是要开始了？
好，可以，请开始。
Okay, let's start. I will introduce you. Okay. Welcome to the Frontiers in Dementia Research. Today, I will introduce our distinguished speaker, Dr. Charles DeCarli. Dr. Charles DeCarli is a distinguished professor of neurology at the University of California in Davis, California. And he's a director of UC Davis Alzheimer Disease Research Center, United States National Institute has founded Alzheimer Research Center. He's also a director of the Imaging of Dementia and Aging, IDEA laboratory. His research focuses on using advanced structural and functional brain imaging to study normal aging, mild cognitive impairment, and dementia, and the role of genetics, diversity, cerebrovascular, and Alzheimer's disease on this process. He's a recipient of the J. Allyn Taylor International Prize in Medicine, Imaging of the Aging Brain, in recognition of his work. He had been visiting Taiwan for many times and helped us in dementia research study. We are becoming increasingly aware that dementia may result from multiple diseases, either independently or in combination. And Dr. Charles DeCarli is an expert of vascular cognitive impairment, an expert of neuroimaging. Let's welcome Dr. Charles DeCarli.
thank you. It's a real pleasure to be here, everyone.
Okay, Dr. Gu may have something to talk.
No. Yeah.
Okay.
Professor DeCarli, please. Thank you.
Okay. Do I need to share my screen again? Or can you
Yes.
see my screen? Can you see my screen?
No.
Okay, got it. Let me share. Here you go. Can you see my screen now?
Yes. We can see your slide.
Perfect. Let me just do one really quick thing. Okay. I want to thank you all. It's a real honor to be a part of this august series. I was just looking over all the inviter speakers you have, and it's really impressive. I feel like I'm the least of those tremendous researchers who are going to be talking to you over the next few weeks. So it's a real honor to be part of that group and have the opportunity to talk more about my interest and my clinical experience. So I'm going to speak about vascular cognitive impairment. I like to give my disclosures. I do have consultancies with various pharmaceutical companies. Most of them are related to Alzheimer's disease and not related to vascular dementia. I'm going to go through a series of themes. The first theme is to talk about a revised concept of dementia pathophysiology, and as a manner to introduce vascular cognitive impairment. And then for the clinicians, really focus on the clinical criteria, the imaging criteria, the pathologies that we see, and then focus on the prevention and treatment and try to kind of tie this all up together in the next about 40 minutes. What do we know about dementia? When we look at a group of people who we think have clinically probable Alzheimer's disease, they present with slowly progressive memory impairment that's typical of Alzheimer's disease. What we find is an entirely broad spectrum of pathologies. And what differentiates those people who have that dementia that looks like Alzheimer's disease from people who are normal or who have some mild disease? And it appears that it's the addition of another pathology. So when we look, this is about 1,000 consecutive individuals assessed at the Rush Alzheimer's Disease Center, and about a little less than a third of them were completely normal after many years of observation. And look, some of them have Alzheimer's disease as seen as AD. Some of them have other dementias. Many of them have vascular disease, seen as the V here. Okay. As we move to those who were seen multiple times and may have been diagnosed with mild cognitive impairment but not dementia, what we see is the AD, the pure AD piece stays about the same as the normals, but then you see AD plus vascular disease, or vascular disease continue to be strong pathologies that are present. And in fact, AD plus something else plus vascular seems to be growing. And then we look at the people who they look for all the world to have Alzheimer's disease. And when we looked at their brains at death, they had Alzheimer's disease plus vascular disease, Alzheimer's disease plus vascular disease plus another disease, other diseases plus Alzheimer's disease, mostly Lewy body here. And that pure Alzheimer's disease actually gets smaller. So this says to me and to many of us now that the idea that there is one clinical syndrome and one pathology is no longer applicable. What aging and dementia is a sign of is multiple brain injuries. And Patricia Boyle, also at Rush, did this marvelous study where she simply asked the question, how many of these pathologies hang together? And how common are they? And this is over, again, over 600 individuals. And what she shows is that 3 major pathologies accompany most everything that we see, okay? But, so they are vascular disease in red, other diseases such as hippocampal sclerosis, Lewy body disease, TDP-43 in green, and Alzheimer's disease in blue. And you can see the number of people who have these diseases is very high with Alzheimer's disease, second with the vascular, and third with these others. But they go in any combination you can possibly in here. And the numbers are seen here, but it doesn't really make much sense. But what you can see is that pure Alzheimer's disease and Alzheimer's plus vascular disease are very, very common contributors. But there's all kinds of mixtures, meaning that if the brain gets enough different pathologies, you will end up being demented. And that while Alzheimer's disease may be the most common pathology, others are contributing. And so a meeting that was conveyed back in 2015 led to this notion by the National Institute on Neurological Diseases and Stroke, that this idea of stroke having no symptoms of dementia, vascular disease, which is atherosclerosis, like in the carotid arteries, having no symptoms of dementia, Alzheimer's disease being a symptom of dementia, other diseases being pathologies of dementia, and that vascular cognitive impairment and dementia sits at that intersection, mostly with vascular disease, but often with the associated Alzheimer's disease. there have been many different guidelines published. The most common guideline is this NINDS AIREN International Workshop for Defining Vascular Dementia that was done some years ago, and I'm honored to be one of the authors of this. And this served for quite a long time as the clinical definition of vascular dementia. What we are realizing is that vascular cognitive impairment moves beyond dementia and involves every aspect of cognition. So you can have questionable cognitive impairment with vascular disease, mild cognitive impairment with vascular disease, and dementia with vascular disease. And this led to the American Heart Association, American Stroke Association scientific statement in 2011, which I was again honored to participate in which we looked at a better way to define vascular contributions to cognitive decline and dementia. And here's what we came up with, is that the important feature of this new definition is that all deficits, the entire spectrum of cognition can have at its origin vascular disease. So like I said, questionable cognitive impairment can have vascular disease as its origin, mild cognitive impairment, and dementia. The definition of dementia, however, remains that there is an impairment sufficient to require dependence in one or more activities of daily living. The difference with this new definition is this caveat, is that the deficits in activities of daily living must be independent of motor sensory impairments due to vascular events. So let me give you an example. Someone has a right hemisphere infarct, they have a left hemiparesis, that impairs their activities of daily living, so they need a little help taking a shower. Okay, but their cognition can be completely normal, and therefore they don't meet the criteria of dementia. Now, the other aspect that's very important is that there must be imaging evidence, and there must be imaging evidence for, if it's to assume that vascular disease is the only cause, imaging evidence of vascular disease and a clear temporal relationship. And what do I mean that? Someone has a stroke, and within the next month or two, they're demented, or they're demented shortly after this, or with the stroke, okay? Now, if it's not a clinical stroke, but there is other diseases with sufficient vascular disease that follows suit. So CADASIL is a perfect example where there's subcortical vascular brain injury that is progressive and is seen as progressive lesions on MRI or CT. The other key part is that it is time locked and associated with the vascular disease. And this is where we say, in terms of probable vascular dementia, using definitions now just as terms, is probable vascular dementia means someone for whom their entire dementia course can be attributable to vascular events, either symptomatic or asymptomatic, and that there's no prior history of slowly progressive dementia prior, particularly one that would suggest Alzheimer's disease. Possible vascular dementia, of course, is when there's some of these attributes that are missing. Now, one of the problems that I'm sure that those of you who are actually in the clinic and practicing medicine face all the time is that what happens if someone has a stroke and has an aphasic disorder? And how can we say if they're demented? And this becomes a little bit more challenging, but what we do as a clinician, what I do as a clinician is I say, okay, how is this person functioning before the stroke? And how much does the aphasia affect the disabilities that the person is experiencing after the stroke? Or is this a person who has had a stroke for a while, had an aphasia, but has been doing quite well and has had further decline with another stroke? And we'll I'll show you a couple of vignettes where we discuss that. But it is possible to make a separate diagnosis of dementia, even in the setting of an aphasia. When we talk about vascular dementia, I talk generally in three categories. Multiple infarcts, usually large, completed in strokes that involve either the cortex or large subcortical areas. Strategic infarct dementia, in which there are unique areas in which hemorrhage or stroke affect certain circuits that lead to a classic dementia picture. And then by far the most common is subcortical ischemic vascular dementia, in which you have extensive white matter disease, lacunes, and maybe microhemorrhages. And these all have various names and have different disorders associated with them. The clinical features of an infarct dementia is usually a sudden onset of cognitive impairment in association with a stroke-like symptom, a stepwise decline in cognitive ability at the time of the event, and of course, a simultaneous or nearly simultaneous determination that this person has evidence of a stroke on brain imaging. The subcortical is more likely to be what we call a slowly progressive cognitive motor syndrome. And by that, I mean that there's cognitive components, but that they often have some kind of pyramidal or extrapyramidal appearing abnormalities on exam. They may have a mild hemiparesis, they may have dragging a foot, but it's subtle. They can also even have a vascular Parkinsonism-like syndrome. So that's the cognitive motor piece. One of the challenges we faced in this area of vascular cognitive impairment is defining what is vascular brain injury and how does it relate to the dementia syndromes. And up until recently, and Olivia Scrobot, which I really admire, in England, decided that she would really try to take a look at this. And she started by saying that there are no generally accepted guidelines for postmortem assessment of people with vascular cognitive impairment. And so she took about to study what were the three most predictive features of cognitive impairment across the spectrum, okay? So this is, in other words, the low likelihood that you have any cognitive problems due to vascular disease to very high likelihood that you had cognitive problems due to vascular disease. And she based this on the fact that most of these people had large subcortical cerebral infarcts. And so and she used these that in tandem with many people had vascular pathology related to CAA. And then finally, the third that she used is severe arteriolosclerosis of the white matter. And it's not important that you understand these neuropathologies so much as it is to understand that this is a first step in how we can begin to define how we can look at the contributions of vascular disease to impairment. And so if you have none of these three diseases, or you have mild, or if you have moderate to severe CAA, you're still likely to be low in likelihood that vascular disease is a major contributor. But as you begin to have additional evidence of either the infarcts or the arteriolosclerosis or the CAA, then your likelihood of becoming of having vascular contributions to cognition increase. And if you have all three, it becomes high. If you have two or three, it is also high. Another study that helps confirm this, that was actually done years before, was by David Notman, who reviewed a series of neuropathology cases from the Mayo Clinic. And what he showed is very similar. If you have multiple infarcts and that they are large and involve the cortex, that is most likely to cause sufficient to cause dementia, even in the presence of Alzheimer's disease. What he showed is that there are people who had no Alzheimer's disease and were fully demented with this level of pathology. However, there were some people who had mixtures of Alzheimer's disease and smaller neuropathologies who then looked very similar and had a dementia. So, where the relevant diagnostic features then are the temporal link. Is someone asking a question or? So is there a temporal link between stroke and the onset? And he showed that, in fact, that seems to be the highest predictor, making it 6 times more likely that you have vascular dementia. Are there bilateral infarctions in the cortex? Again, about 5 times more likely. And either of these above combined makes it very likely. So what we are seeing here is that the phenotype of vascular cognitive impairment is a little bit complex. You can have at least 3 different kind of clinical presentations. But that if you're careful and you get a history of clinical stroke, specific motor signs, and that there are specific cognitive syndromes, and these all are consistent with vascular cognitive impairment. And remember, Alzheimer's disease does not include vascular contribution. You can have someone who has both lacunes and has Alzheimer's pathology and will look like an Alzheimer's disease patient. But in that case, the vascular disease is clearly contributing. So what helps us to make the diagnosis? In this case, in vascular cognitive impairment, good brain imaging is essential to the clinical diagnosis. And of course, we look for things like large cortical and subcortical infarcts. We look for small strategic infarct. We look for lacunes. We look for white matter hyperintensities. We look for microhemorrhages. And actually, even more recently, we're starting to look at dilated perivascular spaces. And I won't go into that too much today, but it is an important issue that is emerging. And the other thing is people with vascular cognitive impairment have just as much atrophy, including they too can have hippocampal atrophy, just like Alzheimer's disease patients. So atrophy is a part of this imaging profile. And this is a summary done by my colleague Prasante Vermuri, Marco During, and myself last year. And we're just reviewing the necessary imaging criteria or helpful imaging criteria of vascular cognitive impairment. And obviously a stroke, as seen on DWI, is important. What we have noticed, and I think others have noticed, and that sometimes you'll see this DWI only transiently, and you won't see an obvious infarct afterwards. But we still believe that that is sufficient vascular injury, sufficient to call that vascular contribution. Of course, white matter hyperintensity we speak to quite a bit, and you can see that it's usually around the ventricles, extending to the subcortical white matter, and then can be scattered throughout the subcortical white matter. Lacunes, as you see here, are holes and often surrounded by a halo of white matter changes. There is ideal. The microbleeds that you see mostly in the occipital cortex that represent cerebral amyloid angiopathy, but these could be hemorrhages, they can be elsewhere in the brain, and they can be subcortical and be associated with hypertensive encephalopathy. Superficial siderosis, which is relatively uncommon, but may be evidence of ruptured amyloidose involved vessels and leading to this siderosis. And of course, now with better imaging, you can sometimes even see small infarcts in the gray matter. These are not truly micro infarcts in the sense that they're in the area of 250 micrometers across, but more like half a centimeter, millimeter or two, just above the resolution of MRI. So they're sort of a micro macro, but they are, when you see one of them, there are often many of them. So what do these findings mean? Well, as I was just saying about the dilated perivascular spaces, this is work that's under review by Rafael Romano at Boston University, showing that if you have a large amount of these enlarged perivascular spaces, your risk, particularly if they're in the centrum semioval valley, your risk for developing dementia becomes quite high, and the survival rate is like 40% after 15 years, which is a fairly significant drop-off in survival. If this is data from Stephanie DeBet and I from quite a long time ago, but if you have extensive white matter, your risk of developing dementia over time goes up. If you have a subcortical infarct, even if it's not symptomatic, your risk for dementia over 4 to 6 years or 8 years goes up significantly. And Raphael has also looked at the microhemorrhages and shown that there's a modest risk, particularly if they're scattered throughout the brain, for increased likelihood of having a dementia. Now, a group from Korea who I continue to call my colleagues and we've collaborated with did a really nice study that helps to understand what about the cognitive profiles. So they looked at a group of subcortical vascular ischemic individuals and did amyloid imaging and then tested their cognition. And this is a small group, but an important group. And so if you look on these two panels, you can see that both of these groups look pretty similar. They have a lot of white matter disease. Don't be fooled by the intensity differences. It's simply the contrast of the windowing that was done. But this person, this individual with a lot of white matter disease, clearly suggesting vascular disease, also had amyloidosis and therefore had a mixed picture. This person who has lots of dilated perivascular spaces, some subcortical infarcts, including in the thalamus, had cognitive impairment without any amyloid in the brain. And so this is a perfect example of how we're differentiating these in vivo using combined multimodal imaging methods. But what was more interesting is that the individuals who were had no amyloid in their brain, their verbal memory was actually almost normal, whereas the Alzheimer's person, the persons that had Alzheimer's pathology in their brain had pretty severe impairment in verbal memory and was really amnesic using the delayed recall. So it's clear that what it states is that true amnesia is uncommon in vascular dementia and indicates that you were likely looking at a combined process. And so most recently, the National Institutes on Neurological Disorders and Stroke has come together to develop what's called the MARC VCID Consortium. And this, why is this important? Not only are they putting together neuroimaging protocols, but they're designed for clinical trials. And so these are a group of people gathered together to develop a clinical trial ready imaging program that if medications are available, we can begin to do in-depth studies of treatments for vascular dementia and vascular cognitive impairment, which I think is a really important feature and a step forward in what we need to do to move this forward, therapeutics forward, because it's probably going to be more than just prevention. We're going to need to have some treatments. one aspect that's come out of that, one method that's come out of that is my colleague, Pauline Maillard. She's been with me working in our lab together for about 8 years now, and she is just really doing a fantastic job. And she identified a marker on diffuse intensity imaging called free water. And I won't get into all the details about it, but the bottom line is this appears to be a sensitive measure. And so what we did here is looked at our longitudinal cohort in our ADRC and had individuals who had, we looked at about 500 individuals, 312 of them had just baseline imaging, and 224 had longitudinal with multiple cognitive assessment. And what we found is that if you looked at baseline memory and baseline free water, there was a very strong association. Same with baseline executive function and baseline free water, and baseline CDR, which for not everyone is familiar, although John Morris did precede me and may have talked about the clinical dementia rating scale. This is a dementia severity scale. And the important point here is that it was also sensitive to those people who met the clinical criteria of dementia. That the strength of these relationships were much stronger than with white matter hyperintensities. Not only that, but this also predicted change. So at baseline, this predicted change in in cognition and incident decline towards dementia. So the imaging features of vascular injury are becoming better understood, okay? And I would say that if you take white matter hyperintensities and infarcts, subcortical brain infarcts, or small cortical brain infarcts, or silent brain infarction, these are fairly strong and sturdy determinants of concomitant vascular injury. And that the consortium, the MARC VCID consortium, is digging deeper into this to see if we can come up with a suite of imaging methods that will allow us to then use them as outcome measures in treatment. And I think the one on the horizon for us is this free water measure. And the other point is that the presence of amyloidosis does not exclude vascular disease as a contributing factor to the cognitive impairment. So the two can be co-contributors. So let me just take a moment to walk through 2 clinical vignettes to give you a sense of what I mean. And the first is an example of someone with clinically probable vascular dementia due to a stroke. In brief, this is a 69-year-old gentleman who presented with a history of a TIA, and then he subsequently went on to develop problems with memory, and he had symptoms of vascular risk factors such as hypertension, hypercholesterolemia, diabetes. He also had disease such as coronary artery disease, aortic aneurysm, and peripheral vascular disease, including carotid vascular disease. He did fairly well at his first evaluation, but he had evidence of his of an old stroke. And on imaging, there's evidence of a right occipital parietal infarct seen here on these different slices, and suggestion of an anterior infarct, possibly clearly on the left, but possibly also on the right. And this is a person who presented with, quote, TIAs, but in fact had infarcts. He returns, and now he's doing much worse. And what's typical of our cohort with vascular disease is that he had an MI, and he had to have a repeated left carotid endarterectomy. So he's got progressive vascular disease, systemic vascular disease. He had a new stroke 10 months later, and then became fully demented. And yet, if you look at his mini-mental, it was still quite good. He was not densely amnestic. At neuropathology, what we see is this brown that is in an old chronic infarct. Interestingly enough, this is a silver stain of the hippocampus showing relatively preserved neurons. And so he had actually all vascular disease, no Alzheimer's disease. Now, what about another example where someone comes in a little bit more nuanced? So this is a 78-year-old gentleman who started with memory decline. He then developed mild problems with language, including comprehension. However, just before this all started, he had had a stroke, but it only caused him to have a mild left hemiparesis. The cognitive symptoms started in 2003, and they included having some impairments in terms of his daily activities, including difficulties with organization, taking medications. Yet, look at his mini-mental, he's doing pretty well. He is not amnestic. He had been placed on Aricept, and we decided, could this be partly Alzheimer's disease? So we increased the dosage. Again, his past medical history is really relevant for his stroke, mild hypertension, high cholesterol. He was on a cholesterol-lowering medication. Of course, importantly, and I think, is that he had 100 years of smoking, and his mother had late onset Alzheimer's disease. He did well. He had his mild hemiparesis. No decline after a year. He, though, has no longer drives, and he's having more trouble with his basic ADLs. But he continues to go to church, he bowls, he exercises. Again, his neurologic exam looks pretty good, except for the hemiparesis. His 2 years later, his mini-mental declines a little bit, but then 5 years later, he really does decline, and now he's diagnosed as moderately demented. He dies of a pulmonary embolism and has no additional history of strokes. And this may look familiar to you all. Again, on his MRI, what I see is a lot of atrophy and kind of like chunks, bites taking out, with lots of white matter hyperintensity, and importantly, a lacume here in his right thalamus. And this is seen even better, the lacume in the thalamus is seen even better on the T1, but you also see there are probably other lacunar infarcts in the right frontal lobe and some of the basal ganglia. Oh, by the way, his hippocampi are small. He has amyloid imaging, and lo and behold, he has a positive amyloid scan. Okay, so we're thinking, Alzheimer's disease with a little bit of vascular disease. Okay, but what we see even on the gross exam is that he has many small infarcts. And this is, for those who are not familiar, this is the gross brain where you're looking at the major artery coming up to the back of the brain, and there's just severe atherosclerosis. And the atherosclerosis in the carotid arteries is so severe that the arteries they're just standing out, and that's very uncommon to see. And it's a little hard to see here, but what I'm going to do is zoom in and show that he has infarcts, microscopic infarcts all over the brain, including the hippocampus. So here's the hippocampus. Here's this area, and you can see that there's just loss of nerve cells in the hippocampus due to infarcts. There's amyloid in the brain, and it's moderate, but not severe. There is rare tangles, however. And then there, as I said, there are many areas of microscopic infarct. And this is an example of a white matter hyperintensity that has essentially necrosed in the center. Here's another example of a white matter hyperintensity that's essentially necrosed in the center. And so he had cerebrovascular disease. What was surprising is he had very modest Alzheimer's disease. So this is a person who has a history of stroke, but for all intents and purposes presents in the classic way of Alzheimer's disease and had vascular disease as a primary cause of this cognitive disorder, even though mild Alzheimer's disease was present. So that the preponderance of the weight was on this, and this case touches ideally on the fact that co-occurring pathologies may be present, but in this case, vascular disease was the major contributor to the cognitive impairment syndrome. Now, I brought up the point that this person had a stroke in their thalamus. There are rare cases, but not too rare, where strategic infarcts in the thalamus, particularly usually on the left, this is the right, can lead to loss of memory and executive impairment, such as to the degree that these individuals meet the criteria for dementia. Similarly, a left parietal infarct or hemorrhage can lead to finger agnosia, the inability to recognize the fingers, confusion with right and left-sidedness, difficulty doing calculations, and sometimes inability to name things, and that's called the Gershman syndrome, and it too can be considered a dementia. What we're beginning to learn, and this is a really nice study done by the group in England who have started, the ones that came up with the STRIVE criteria, and now they're focusing on looking at individuals with small infarcts and asking where are they located and which ones are associated with cognitive impairment. And what you can see is these single infarcts around the thalamus and in the subcortical are the most strongly associated with cognitive impairment. Another group is formed called Meta-VCI, and this is a multinational group led by oh golly, I'm blocking now. Oh, I'm sorry, out of Europe. But the bottom line is that they're starting to use multiple overlapping maps of white matter disease and infarct, and asking what areas are most critical for risk for dementia. And you can see in the red how nicely this is showing that there are these posterior and left anterior cortical areas that seem to be, temporal areas that seem to be most significantly associated with post-stroke cognitive impairment. So vascular brain injury affects cognition in a variety of ways that include clinical phenotypes that overlap with Alzheimer's disease. And I think that's the point I'm trying to make here. The emphasis is identifying and estimating enough vascular disease to be sufficient to impair cognition. And I hope if you've seen there clinically what those might look like in individuals you may see in your own practice. Excuse me, sorry. So how do we go about treating these patients? We identify risk factors, obvious risk factors. Less common are sleep apnea, and I'm becoming more and more sensitive to this. CHF, and as we're beginning to understand that heart failure doesn't have to be the same for all people, so there are different flavors of heart failure. And then the rare cases of elevated homocysteine. And I do regular laboratories, but the things that I sometimes will focus on a little bit more will be either 24-hour blood pressure monitoring or 48-hour ECGs. Look for nocturnal hypertension, look for atrial fibrillation, intermittent atrial fibrillation, possibly a sleep study, echoes, and rarely a CT angiogram if I believe that there is a lot of small vessel atherosclerosis that could be improved using secondary prevention treatments. What are the secondary preventions? Right now, we tend to look towards aspirins and antiplatelets, statins, anticoagulated if indicated, particularly in those who have either intermittent or continuous atrial fibrillation. I will say that we want to, and I'll introduce this in just a second, ideal control of vascular risk factors. And one thing that's emerging are the GLP-1 drugs that are being used for diabetes right now. And I think these are unique glucagon-like proteins that I think are going to prove to be important to vascular health. And so this data is just coming out, and if I speak to you again, I may have an update for you. What is ideal cardiovascular health? Well, this is Donald Lloyd Jones's what we call Life Simple 7, and it's just looking at these 7 life behaviors: smoking, diet, physical activity, body mass index, and treatment of blood pressure, cholesterol, and sugar. And what we can see that is in a population, the higher the number, the healthier the health, okay? And what you see is that there's a distribution of these health behaviors. What's important is that a nice study that was done some years ago, but published only in the last 5 years, of almost 20,000 people across a large span of the United States, asked a simple question: is how is their Life Simple 7 performance, and how is their cognition? And what you see here is that both in African Americans and white European Americans, that we see that people who have healthier lifestyles are much less likely to develop cognitive impairment over time, or have cognitive impairment at the time they're evaluated. And that this is a effect primarily in that the people with the worst health have if they have any improvement, they're reducing their risk. You may have heard of the Sprint Mind study here in the United States, where we looked at the aggressive hypertension control versus normal hypertension control and the impacts. And here's the result of that study. And what it shows is there really was no difference for the first 4 years. But what made the biggest difference was after 4 years. And it became significant. And the important point that I want to make with this is that treating blood pressure aggressively is a lifetime issue. And what was really interesting is these results were not influenced by their age, their race, their cardiovascular history, whatever their baseline blood pressure. So the point being is that having a lower blood pressure is healthy for your brain. In addition, another team working in the Sprint Mind study showed that the white matter hyperintensities did not grow as fast in the aggressively treated, suggesting that again, the white matter hyperintensities are a good biomarker, surrogate biomarker of successful vascular mitigation of vascular disease. So the vascular disease, brain injury, is common to older individuals. The goal of treatment is to identify the extent and risk factors may contribute, and mitigate further injury through ideal risk factor control and secondary stroke prevention, in addition to what I talked to you about, may include this new class of drugs. And I'm very hopeful to see how this plays out. And with that, I want to just thank you. And if my colleagues will allow me to answer some of the questions that I saw flash by the text, the chat, I'll be happy to do so. I'll stop my share now.
Thank you, Professor DeCarli. We have one question that we have two questions. The first one, is there any specific pattern of brain MRI vascular lesion to differentiate the pure SIVD and the mixed AD and the vascular disorder, vascular dementia?
Yeah. I would say that the presence of multiple lacunes and extensive white matter disease is going to be the strongest differentiator between pure AD and AD plus vascular disease. Yeah, that and then the second question, are there alternative ways from amyloid PET and autopsy to identify? That's a really good question. And what I will say is that we're working on plasma biomarkers, plasma AD biomarkers, to look at the presence of amyloid beta and phosphorylated tau in the plasma. We're not there yet where we can say it's specific to an individual patient, but we're getting there, and more sensitive and specific measures are being developed. And so I am cautiously optimistic that we're gonna get there. And so I don't think we need PET for the diagnosis of Alzheimer's disease. We will. Let me say this clearly. I don't believe that we're going to need PET to diagnose Alzheimer's disease in the next 5 or so years. We will have enough evidence using other measures to get our answers. And I think that the biggest step forward will be these sensitive and specific blood measures that will help us make the diagnosis. Yeah, what kind of brain vascular lesions come out first? I think that infarcts are usually the first thing. So usually people have some lacunar infarcts on their brain. Then they're accompanied by white matter hyperintensities, or they'll have white matter hyperintensity followed by lacunes. That pairing that I talked about really does suggest that there is vascular disease contributing to their dementia or impairment, or that vascular disease is present in the brain and should be treated. The other things that come out are then the atrophy, but I would say that those are the real lesions that I would focus on. Yes, okay. That's does a stroke-associated dementing patient benefit from angiogenesis inhibitors? Good question. There is this, so for those who are not familiar, there is this concept of pathogenic angiogenesis. And the answer to your question is I don't know. And I don't know because I don't think anyone knows. But we've been looking at one angiogenic factor, placental growth factor. And what we see is that as it goes up, so does the likelihood of cognitive impairment after vascular disease. So I think there's something about aberrant angiogenesis. We just don't fully understand it. And we think it's a response of the endothelium to some kind of structural dysfunction. And we just need to understand it more clearly before we talk about inhibition, or maybe there's multiple arms and we want to push the angiogenesis in a healthy way versus an abnormal way. What is the progression rate? No, these are really excellent questions, by the way. What I would say is, by and large, subcortical ischemic vascular disease tends to progress more slowly. And I'm often cautiously optimistic when I find someone who has some correctable risk factors and are only mildly impaired. So by and large, these individuals do progress more slowly. Yes. Is the white matter free water associated with the glymphatic system? That is a fantastic question. The answer is, I don't know. But what we are pursuing right now is the question, is it related to blood-brain barrier dysfunction? And I believe that there's probably some endothelial gap problems, either because of the astrocytic foot or the periocytes are not functional. And so there's the dysfunction allows excessive transudation of fluid into the brain. Now, that means that fluid's not being cleared normally. So in some sense, it is related to lymphatics because the fluid isn't being cleared normally, but I think it's proximal. It's on the arterial end of the lymphatic system, not the venous end of the lymphatic system. Yes, is dilated perivascular spaces related to VCI more than infarcts or what? It looks like in the data that you saw, it looks like they're very strongly associated with dementia, and you think, okay, well then maybe they're a better indicator of VCI. What I would say is that we don't know their relative contributions. I think what they're probably is a good marker of arteriolosclerosis, and that's the artery thickening due to excessive pressure on the brain. And so in that sense, it's a component. I try to think about that as a disease of the vascular system and not a true brain injury. It gets a little bit tricky when you're seeing that the cause of this dilated or enlarged perivascular space is due to a change in the vessel that's injuring the surrounding brain tissue. So that's a good question that doesn't have a great answer. And I'll just say, stay tuned. We're looking into this. Yeah, how well does plasma p-tau? On a group level, plasma p-tau seems to be working quite nicely. The group from Jotunberg has done a wonderful job at developing very sensitive measures. The issue becomes whether or not that you try to think about it. There are two issues. One, first is, does it work at a single person level? And the answer is no. It works in the group levels, but it's not very specific. So it's not a diagnostic marker like a PET scan would be. Second is, again, don't get caught in the trap of Alzheimer's disease versus vascular dementia. Talk about vascular disease and Alzheimer's disease. And I'd say that tau may actually go up in vascular disease. We just don't know much about it yet. And there's some work that's coming out of Korea, actually, that is suggesting that, in fact, even vascular disease increases phosphorylated tau. How do we how do we evaluate the potential for neurological complication and neurodegeneration after stroke? The neurodegeneration after stroke is really important. What I do see in my stroke patients is that you see the stroke and let's say it's 3 centimeters. You follow that person for 2 more years, it's now 4 centimeters. That means that there is further degeneration going on, and so they're not compensating. In someone who you see 3 years later and it's either the same size or it's gotten smaller in some cases, that's someone who's compensating, and generally their clinical course will follow that. Well, I think that brings me to the end of my talk, and thank you all very much.
Thank you, Dr. DeCarli. I'm very impressed about the discussion and your talk. Yeah.
Right.
If you have more questions, maybe you can email to Professor DeCarli. And thank you very much. Yeah. And thank you.
Right.
Yeah.
Take care, everyone.
Thank you.
And have a wonderful rest of your day. And I hope that you can get out and have some lunch.
Yeah. And good
Bye-bye.
night. Mm-hmm. Mm-hmm.
Bye-bye.
Mm-hmm.